Hi all, my name is Ger O'Dea, the Community Engagement Manager with the National Ambulance Service. I've come here today to Rathcoole to... You might know Peter from such shows as Paramedics 1, Paramedics 2 and Paramedics 3. I'm delighted to be taking part in this year's Virtual Respond. I'm down here in Rathcoole in North Cork with the crew of Helimed-92 to give you all a virtual tour of one of the country's aeromedical services.
Hi, my name is Peter DeLay. I'm an advanced paramedic supervisor with the National Ambulance Service.
My name is Edward Walsh. I'm an emergency medical technician.
My name is Donagh Verling and I'm one of the pilots here with Helimed-92.
So part of our morning checks before we ever go near the aircraft with the pilot is checking all our equipment. We're in a bit earlier than the pilot and we go through all the bits of equipment just to be sure everything is where it should be. We replace, once we do a call, the minute we come back from the call, we replace all the kit that we use. So it's just in the morning, usual checks with the defib, a visual inspection of every piece of kit, just to be sure everything's 100% for the day, and load it all into the heli.
So that's all our equipment in. I'm now going to pass you over to Donagh, who's our pilot, and he'll explain the next part.
First thing we do when we come in the mornings is to prepare for whatever calls we might get in the course of the day. So you can't just come in, get into the aircraft and go flying. So part of that preparation means that mechanically the aircraft, everything looks like it should look. Each morning I come out and I do a walk around, so I check the fuel that we have in the aircraft to make sure that the oil levels, there's no obvious damage to it. And then we wheel it out then and start it up to make sure that all the systems are working correctly. And then all the pre-flight checks are effectively done beforehand in advance, and then the aircraft is sitting on the pad ready to go at short notice in the event of a call coming in. So all that takes about between 30 minutes, 40 minutes in the morning before we're technically ready to go. We have a fuel load in the aircraft that allows us to respond to pretty much anywhere in the country. We've about roughly 2 hours and 20 fuel available to us. So that's what we leave in the aircraft at any one time. When a call comes in, once we've established that it is something that we will respond to, we've covered all the basics of weather conditions and what to expect. It's generally less than 5 minutes from when the call comes in to us actually getting airborne and departing. So I effectively come out and start up the aircraft. The two guys will be inside still taking down more details, and I'll get the aircraft ready to depart. So by the time they come out, they sit in, we do one final check that we've covered all the essentials, and we head off.
For me, as an emergency medical technician, my role in the Helimed-92 operations at scene is to coordinate between the scene and the helicopter as a safe manner to load a patient into the aircraft. The medical crew of Helimed-92 have to undertake a week's worth of training in medical upskilling in terms of, for myself, as working with an advanced paramedic, I have to learn the medications that they undertake and give to patients. We also have to understand of technical crew member, which when we're in flight, our clinical levels don't come into it. We are within flight, we are helping the pilots to navigate, talk to air traffic control, and also keeping aware of height obstacles like mountains and wind turbines.
We've done courses in navigation, mapping, aircraft safety, and those courses enable us to be a technical crew in the helicopter. So our pilots get into the helicopter, they usually know roughly which direction we're going, but they don't know exactly where we're going. It's up to us to navigate the pilots to the scene. Myself and the EMT would always, when we get a call and the pilot gives us a thumbs up for going out, that we're okay to go to the area, myself and the EMT would then stay in the cabin, plan the route, plan the best way, note if we're going into any air traffic control zones, We'd have a look at the scene and see roughly where we think would be a good landing spot for the scene. When we get overhead of a call, that's when we decide whether or not the scene is actually correct, where we're going to land. There's a number of things that influence that. So there's wires, there's the positioning of where the patient is. There can be, if there's animals, people, any debris in fields and things. So there could be electric fences, even access for us out of fields and things can determine whether or not we'll use a landing spot. So sometimes we don't always land right next to where the scene is or where the patient is. Sometimes we'll opt to land somewhere else. The biggest thing about helicopters and HEMS work is safety. Safety is paramount for us and for people on the ground. We'll get a telephone call from the Aero Medical Desk in the National Ambulance Control Centre in Dublin. They have a designated desk that's scanning the calls throughout the whole country to see if there's calls suitable for the Aero Medical Service. So once there's certain criteria that are met, and once they see that there's a call somewhere suitable, they ring us, and it's up to myself and the crew and the pilot and the NEOC personnel to decide whether or not we'll go. A couple of things influence that. So you have the weather or not. So sometimes we mightn't be able to fly into Cork, even though it's a blue sky day down in the likes of Castledownbere. We mightn't be able to get the patient to Cork. So the primary role of the HEMS unit is there's two main roles. The first thing is deliver advanced medical care to the person, and then the secondary role is the transport of the person to the hospital.
Not all hospitals have helicopter landing sites, but the reason why we do what we do is to take the casualty to the most appropriate hospital where they can receive the appropriate level of care. So that tends to be the more major trauma centres, so the likes of CUH, Limerick and Tralee would be the main ones that we go to. So those three receiving hospitals, depending on the nature of the injury or the casualty we're picking up, those ones have hospital landing sites. And then the other hospitals around the country, some of them have helipads, some of them have sites that we can land on. So can this aircraft fly out to an island? Yes, it can. But that's the primary remit of the Coast Guard. So there's 4 aircraft based around the country, and they have primary responsibility for the offshore islands. If one of those isn't available and we need to go out, well then that's something that we can, the aircraft is capable of doing, but it wouldn't be something that we do on a regular basis. Things like, Bear Island and Cape Clear that are literally, you're going across effectively a river or a small lake, well then obviously we can do that. But the offshore islands, we can go, but that's the primary role would be the remit of the Coast Guard to go out to those. The aircraft can fly at night, and we can fly at night, but obviously, as I said to you about the identifying the landing site and the hazards that are around it, wires and all that kind of stuff, becomes significantly more difficult at night. So we don't do HEMS landing sites at night. At night we can fly to in between airports, so we can land into the likes of Cork Airport. We've done jobs where we have delivered a patient up to Dublin or whatever and then transferred back down to Cork at night. So the aircraft can fly, we're qualified to fly at night. That is possible, but it's not something that we do on a regular basis. If we land on a scene, so if it's getting towards the end of daylight time, we can land in before it gets dark to bring the appropriate level of care to somebody who's in trouble. So I can land on, and the guys can go out and deal with the casualty as necessary. But unfortunately, if it's after dark, I then currently can't take off out of after that. I'm tucking the aircraft up for the night and trying to find a B&B.
So one of the calls we go on and we're dispatched to quite quickly is cardiac arrests. Locally here, we're sometimes a bit quicker than even the land-based ambulances, where we might arrive on scene first. That was something that really wasn't envisaged when we started, but it has happened. So when we arrive on scene first, we'll assist. We'll start normal BLS stuff until such time as other crews arrive or community first responders arrive to give us assistance, and then we'll go into our advanced role after that.
In terms of what assistance people can give us when we land into a landing site, the main thing you can do is protect both yourself and other members of the public. So that means staying back and keeping other people away. This aircraft weighs a little over 3 tons, so there's obviously 3 tons of air being blown down, which means it's going to blow up small bits of debris or stones or whatever, and the last thing we want to do is injure anybody else when we arrive. So we're trained and capable of doing all the things we need to do ourselves and to manage the landing site ourselves. So as much as possible, if you can keep members of the public who tend to get excited and who, you could have somebody who's a relative of the person who's injured and they obviously want to come as quickly as they can.
Apologies.
Sorry. We'll be back in a minute.
The weather is dodgy.
You could get as far as Mallow and end up turning back. You're not going to be able to bring him into Cork.
So once the phone rings, you might have seen a minute ago, we kind of shut off all of a sudden. It's all hands on deck really inside in our place. I speak to one of the controllers from Dublin in the National Ambulance Control Centre, and they start giving me information. The first bit of information they give me is roughly where the call is, and that's so I can say to the pilot roughly what area we were going to. We do morning briefings and we chat about weather, we chat about any notices that affect flying in the areas. Is there anybody hang gliding? Is there any gliders? Is there an air show? So we do all briefings in the morning with our technical crew role about what's going on for the day. So we have a good idea already about what way the weather is around the country. But we just give the pilot the heads up as to roughly what area we're going to go to. So if it was Killarney in County Kerry, we just say to him, is Killarney okay in County Kerry? He'll just quickly have a quick look at the weather again and he'll give me the thumbs up and say it's okay. The next bit of information is the air code, so we can start inputting it into our mapping systems so that we can start planning where we're going and seeing where it is and bringing up actually the site itself. And then the information, the medical information after that as to what's going on the scene and what's required, what other services are attending, if there's any community responders attending, if there's any need for other aeromedical services to come down and give us a hand and things. So there's a whole clinical side that we chat about as well. All this is done within about 2 or 3 minutes. It takes the aircraft, we're from the time the phone rings to the time of taking off is roughly about 5 minutes from us. So from the second we get that call, it's all hands on deck. Everyone is planning, everyone is busy, and nobody is dawdling. So after that, we make sure the call clinically is suitable for us. So once the call is clinically suitable for us and that we're going to go on, that there's nothing going to affect us and that we're going to be able to help, the pilot goes out and starts up. We plan the route, myself and the EMT will plan the route. We'll have a look overhead roughly from the mapping systems as to where we're going to land. Even sometimes before we go to the scene, we might say we're actually going to land down the road a bit. We might ask if a guard a car or if somebody can come and collect us. So we even have to think about things like that. So we grab our maps, we make sure we have our phones on our helmets out to the aircraft, and what we do is we wait at the aircraft. We never approach the aircraft when the waters are running. We wait for a thumbs up from the pilot that it's safe for us to approach, and there's a certain way we approach the aircraft. Even though we have helmets and safety and everything else on and we're used to approaching the aircraft, we only approach it from a certain point. And then we get in, plug in, make sure we're clear to get into the aircraft, give a quick briefing to the pilot, go through our checks, our technical crew checks then about the system startups, inputting the mapping, talking to the National Ambulance Control Centre, telling them we're mobile and our ETA to the scene, and then we, once we're airborne, we're watching out to be sure there's no other aircraft. When we're flying along, We have air traffic control chatting. We're chatting amongst ourselves about the route and any hazards on the way, whether or not we're flying in and out of air traffic control centres. We're listening to the air traffic control about other aircraft that are in the region and things, and all the time we're eyes out making sure that it's safe. So medically, we're preparing what kind of equipment we might need when we get there. We're having a quick chat about what's going on the scene and what we're likely to see and expect. And then once we get overhead, we do 1, maybe 2 orbits just to have a look down to see where's the best position, what's going on, is there any hazards or anything in our way, and then we'll choose our landing spot and land on and take it from there.
So when we've landed, the pilot will make sure his area around the aircraft is secure by making myself and my colleague will stand out of the aircraft by staying under the rotor disc to make sure no one approaches the aircraft. Once the aircraft is shut down, we'll gather equipment and we will walk out underneath the disc to our waiting colleagues for a handover. So if we land quite far distance away from the original scene, yes, it is appropriate that a C4 could come collect us in their car. As you can see here behind us, we do have quite a lot of equipment that needs to come to a scene, from our ZOL monitor to our Lucas CPR device.
So for transport decisions as to where to bring the people, again, there's a number of factors doing with that. We had a patient who was having a heart attack, or what we call a STEMI, in only out the road here recently, and actually the weather in Cork was quite poor. Cork is a PCI centre where we bring them directly into a cath lab for them to be stented straight away. Limerick was the other option, and actually the call was in between Limerick and Cork. So the transport decision that day was actually to bring the person to Limerick, even though Cork was slightly closer, but we couldn't get into Cork due to weather. Basically, it was just fogged out. So the decision to do that has a number of factors. It depends on what's going on with the patient firstly. So what's their clinical need? We try and bring patients to the appropriate facilities that are going to manage them best and manage what's going on with them best. So sometimes we bypass hospitals or pass over hospitals, and people might think that's a bit crazy, but we're actually bringing them to centres of excellence that manage their conditions appropriately. The next thing is that sometimes the weather has an influence on where we can go into. And there's also instances where we mightn't actually, just because the helicopter arrives, we mightn't ever put somebody into the helicopter. We might decide the best thing for the patient is to actually go with the crew in the land-based ambulance and assist them going into the hospital. Again, it depends on the patient's condition is the main influencing factor. We go to some paediatric calls, so calls with children involved in things. We will always try and bring a family member with the child if we can. There's even on an ambulance, we'll always try and bring a family member with the child if we can. It's better for the family member, it's better for the child, it's better in the hospital, you have consent and things with the adult. Sometimes it can be very nerve-wracking getting into a helicopter at the best of times, never mind if your child is in the helicopter critically unwell, and then you're getting into a helicopter in unfamiliar surroundings, your hearing's taken away because we give you ear defenders, and everything is moving parts, and your child is critically ill on the stretcher. So it's a very frightening thing. The one thing I'd say to a family member if they were in that position is, if you just follow the instructions of the crew at all times. We are absolutely able to manage anything that goes on, even though we might be able to communicate with you. It's a very safe environment. We're absolutely used to flying. The pilots are really experienced pilots. Safety is everything all the time. So if you just leave us kind of get on with our job and manage the child and just be there for them, that'd be great. COVID has had an influence on everything. I think, never mind the medical service on every walk of life at the moment. It has changed how we do things down here. Firstly, communication is slightly harder when you have masks and things. You have to be sure that the message that you're communicating is communicated correctly. We've had to put up a screen between the front of the aircraft where the pilot is and the back of the aircraft where the patient is, so that they're not exposed to patients. Previously, the pilots would have given us a hand bringing equipment and things into scenes and into people's houses. Now the pilots don't come near the scene or the patient most of the time. We wear safety equipment in the aeromedical service with our flight suits and things, and now we have to wear barrier or PPE outside of that. So it's frightening for patients when they see all these gowns and masks, and at the best of times without having all the red flight suits and things as well, it's even more upsetting. But it's all for patient safety, it's all for our safety, and it's to be sure that the service stays running and that there's no issue.
Action.
Take 2, scene 1.
Please.
Hello, Peter.
How are things?
Yeah, we're available. Okay, where to, roughly? Killarney, County Kerry.
Killarney. Yeah, we're good.
Are we good weather-wise for Killarney?
Well,
Yeah, we're good weather-wise for Killarney. Can I grab some of the information? Okay. 36-year-old male. Okay. We get a satellite picture here now, just to have a quick look for Dunner for coming in.
So it's the west side of the town.
Yeah.
We know the lake is the stop.
Yeah.
So
It is quite forestry around the south, but as far as I know, Roscastle has a nice.
November Alpha, Helimed-92. November Alpha, Helimed-92, go ahead. Helimed-92 is airport this time. We're approaching the Rock, Castle, Army, Gary, ETA, 12 minutes. November Alpha, Helimed-92, Roger, 12 minutes to 1 hour.
Okay guys, I hope you enjoyed that virtual tour of Helimed-92 with a very special thanks to Ed, Peter and Donna. I hope you really enjoyed it and enjoy the rest of your day.